ANC, only, I don't know why, but only the anesthesiologists do it. Um, this is the epidural being placed. It's a sterile procedure, so they've got sterile, um, sterile drape. They clean it really well and do it as a sterile procedure. And then, of course, they put a little catheter in, tape it to the patient's back, all the way up usually to the top, and then it's right here. They can just dose it very, very easily. They can leave that in as long. I mean, I've seen patients like not labor patients, but maybe patients have a really big oncological surgery or something, and they'll leave their epidural in for 3 days for pain relief. So they can, you can leave them in. What do you think would be a risk of leaving an epidural in for a long period of time? Infection is a biggie. So they don't like to leave them in for too long. And you really need to be able to assess the site, and you can't because it's covered up. It's hard to assess the site. But infection is a definite concern with putting an epidural. The other thing about an epidural, I thought it was on one of these slides, but it's not. So write this down. I thought it was on here. You cannot get an epidural if your platelet count's less than 100. Just write that down as a contraindication. It might be listed on one of the contraindications you want to next slide. Contraindication, platelet count less than 100,000. Now, 140 to 440 or something like that is normal, depending on your hospital.
Sorry.
Yeah, that's okay.
Harley Farrell.
Mm-hmm.
We need to see Dr. Sayer when Ms. Putnam finishes.
Okay. So, 140 to 440, 150 to 450, depending on, again, on your hospital, that's normal. But they will not put an epidural in until they get platelet count back on the patient. So that's why at admission, every patient in labor gets an H&H and a platelet count. Platelet count on the epidural. If the platelet count's below 100, they will not place it because of concerns about bleeding around the site and then what damage that can cause. That might be listed in the complications. Here's a picture of an epidural space versus the subarachnoid space over here. So that's an epidural placement. What they're trying to do when they bend the patient over, they're trying to these are the vertebrae. They're trying to separate the vertebrae so they can go between the vertebrae. And you can hear it kind of, if you've ever seen an epidural put in, you can hear it cracking as it goes through. It's kind of not pleasant to hear. And what they're doing is they have a syringe attached to it and they just keep pushing, and as soon as they lose resistance, they know they're in the epidural space. Now, that's their first loss of resistance. But they keep going, they're putting in a spinal, but the first time they lose resistance, that's the epidural space. And then once they get there, they thread the catheter through, they give a little test dose to make sure they're in the right space and it's working okay. The test dose goes okay, and then they give the medication. The subarachnoid space, this is the epidural space here, this is the subarachnoid space over here. Okay, I do have it here. Contraindications. I was afraid I didn't have it. Contraindications to epidural. Hemorrhage. So again, platelet count less than 100,000. We will not place it. Hypotension. We know an epidural is going to cause marked hypotension, right? So if the patient's already hypotensive, for some reason, if they're already hypotensive, we don't want to put an epidural in because it's going to get worse. So in addition to that, before we give an epidural, they usually will make you give a 1 liter bolus of IV fluid to the patient before they even do the epidural to try to anticipate the hypotension. And they mostly only do that to pregnant women because what they're worried about is the fetal, perfusion. So what kind of IV fluid are we giving to these patients? We want intravascular volume expansion, right? So what kind of IV fluid are we giving them? Lactated ringers, absolutely. Intravascular volume expansion. That means the fluid that we give stays in the vascular space, helps pump up that vascular volume so that the pressure stays up. If we give saline will pump up the volume in the body, but it won't stay in the vascular space. It'll diffuse out into the tissue. We want fluid to stay in the vascular space, so we use lactated ringers. Pre-existing hypertension, coagulopathy. So if a patient has HELLP syndrome, they've got some clotting issues, right? So a patient with HELLP syndrome, they may not put an epidural in because they're, again, concerned about bleeding and their platelet counts are probably low anyway. Infection at the injection site, we already talked about that. Allergic to the anesthetic drug. What they typically use is a combination of 2 drugs. They usually use a cane drug like Marcaine, bupivacaine, lidocaine, something like that, and then a epidural opiate like Duramorph, which is a special epidural morphine, or fentanyl, a special fentanyl made for the epidural. It doesn't have the same, it may make the patient somewhat groggy. Typically it doesn't. It doesn't have that same response that it does given at IV as it does in the epidural. Patients usually rarely know they've had an opiate when it goes into their epidural. But that's what they usually use, that combination. Maternal refusal or inability to cooperate. So if the patient can't hold still long enough to get 2 or 3 contractions bent over, she can't have an epidural. It is crucial that the patient is still during placement. You got to go thread between that vertebral column, get in that epidural space without puncturing, getting in the subarachnoid space accidentally. It's a very tedious procedure where the patient has to cooperate. So if you've got a crazy off-the-wall patient, she can't get an epidural. She has to be able to cooperate. Maternal cardiac conditions. Some cardiac conditions, again, if they mimic CHF or congestive heart failure, it may contraindicate the procedure. So anesthesia would make that call. So these are contraindications. What are the epidural effects on the newborn? With the exception of the hypotension that the mom has, there are really no effects that it has on the baby. It doesn't anesthetize the baby, it makes the baby sleepy. The only real effect on the baby is what we see is from the hypotension that the mom gets from the epidural, and then the perfusion of the baby is that. Nitrous oxide. We don't use nitrous oxide in this country, but it is becoming more popular again for labor. Again, on Call the Midwife, they use it a lot. Patients just put it on what the theory is the patient takes it, puts it on their face when they want it, and then I guess when they get so sleepy, it just kind of drops off, and then they breathe, and then when they wake up and want it again, they put it. It's kind of self-administered. So it is being widely used in some other countries, and I hear it's becoming more popular in the United States. I have not seen it used. It is a self-administered thing. It's used. So it basically just kind of knocks the patient out when they want to be knocked out temporarily. General anesthesia is rarely, if ever, used for a vaginal birth. There's no reason to do a general anesthesia for a vaginal birth ever. The only time we do it for a C-section is when the patient has to be put to sleep so fast that we don't have time to do an epidural. Because if you put an epidural in, it takes 5 to 10 minutes to get it in, and at least 10 minutes for it to work. So a spinal can work faster, but you still have to have the time to get it in. So in most cases, like Sarah's case, with an emergency C-section, and they need to do it right now. But if you need to do a surgery right now, the fastest anesthesia you can do is general. You can have a patient sleep in 2 minutes if you need to. So that is definitely our fastest alternative. So we don't like general anesthesia. Again, patient doesn't get to see your baby before, and the support person doesn't get to kind of go into the room. And also we worry about fetal respiratory depression from this baby getting anesthesia. So it's not our ideal, but in an emergency we will do it. The most important nursing intervention after the injection of an epidural anesthesia is monitoring what? What do you think is the correct answer? The most important nursing intervention. So that's the highest priority, the most important.
Blood pressure.
Blood pressure.
Yes. Every one of these is right. Not one answer here is wrong. Do we have to monitor urinary output? Yes, because they can't pee. So we're going to use catheter. Do we have to monitor contractions? Yes, because the epidural will stop the contractions. So yes. Do we have to monitor the blood pressure? Absolutely. Do we monitor their IV infusion rate? Yes, we monitor that too because we're giving boluses. But if I said to you, okay, I'm going to send you this patient to receive an epidural, you can only do one thing. I know you want to do all 4, but I'm only going to let you do one thing. What would you pick? You should pick that. Life and death, ABCs, that's what you should pick. But they're all correct answers. So this is basically what's the most important. Maternal blood pressure. So that's why you should pick that. Okay, so we've got 25 minutes, so I'm going to go ahead and start chapter 16. In a perfect world, if we finish 16 and 17, we'll be all caught up by the end of the week. We're exactly where we need to be. So we're skipping 10 and 15 because those are fetal monitoring. So we're going from 14 to 16. Yeah, I'll give everybody a chance in case you need to pull it up on your So this chapter kind of goes right behind chapter 13. It talks about the stages of labor. And what it basically does, it talks about what you're going to be doing for your patient during each stage of labor. That's essentially what this is. It just breaks down. Yes, we talked about the stages, but what are we going to do for our patient during the stages? And again, here's our subphases. Again, like we talked about, latent up to 3, active 4 to 7, transition 8 to 10, talks about the patient's behaviors. And I think it's information that's important for you to know, but I told you I wouldn't test you on it. We've talked about all that. I'm not going to repeat it all. How do you manage care during the first stage of labor? So, nulliparous women or women having their first baby seek admission during the latent phase. You know, again, they get excited about having a baby, so they're usually the first ones in the door. They want to come in because I think this is it. Sometimes it's not it, you end up sending them home. Sometimes it is it, but it's very early. But what I see happen is the longer they are there, the more likely we are to start intervening. I think sometimes we're looking for something to do. Let's intervene. Let's start PIT. Let's do this. Let's do that. Women who are having their second, third, fourth babies, a lot of times they'll come later. They want to make sure it's the real thing first. And they usually do dilate faster. So a lot of times they're the ones rushing in the door and they're 7 centimeters. And I love when that happens. Because as soon as they get there, they're going to have a baby and things go much smoother usually when we do that. So when a woman comes in and says they think they're in labor, the key is, are they in labor? Because I can't tell you how many women come in, even small tips sometimes, say they're in labor and they're not. So how can we tell if they're in true labor or not in labor? Very important. How do we know if they're in labor? Cervical change. There's one way to diagnose true labor. Cervical change. They must be effacing or dilating, or they are not in labor. I don't care if they're contracting every 2 minutes on the dot. I don't care if their contractions last a minute. I don't care about any of that. If they're not doing something, if their cervix is not changing, they're not in labor. So how do you determine true labor? Cervical change. Sometimes we will send patients home, and we've had this happen a lot of times, and they'll keep coming in, they're contracting, and they're 1, and then we send them home, and then 8 hours later they come in and they're 7 and they're mad. I told you I was in labor. And what we usually say is, yeah, you are now, but you really weren't then. And it was bound to change at some point, but we can't keep you here indefinitely for days until your body finally decides to go into active labor. So sometimes when they get mad, I usually say, hey, you were better off. You were way better off at home. So it does happen a lot that patients, they come in and what happens is they just come too early. They're just coming way too early. So if they get up and walk, and within 2 hours, we usually try to get them up and walk if they think they're in labor. If there's been no cervical change in 2 hours, we usually send them home. Now, an exception might be, let's say they're 8 days past their due date, and they come in and think they're in labor, and they're 8 days post due anyway. You know what the doctor's going to say? Yeah, you're here. You're 8 days late. Why should we send you home? Let's just have a baby. So that patient, and do you think they don't ever do that on purpose knowing that? Again, yes, they do. They come in knowing that there's so many days past the due date. If they can get in the door, chances are they'll get to stay. And often they do if they're past their due date. So a lot of times they'll sneak in that way and get themselves. And what they think they think I'm getting to have a baby. What they don't realize is I'm being induced, and I really don't. They don't want to be induced. They just think they do. So once we determine that a patient's going to be admitted in, she's in labor, we're going to admit her. We need access to her prenatal records. Those of you guys who've been clinical with me for things, we've got to get a prenatal record. This is the history of her pregnancy. If assuming she's had prenatal care, we need to see what happened during her pregnancy, what problems she's had. We need access to prenatal records. Now, if a patient is at what we call a drop-in and has had no prenatal care, that's a different story. We don't have a prenatal record. But we need to see copies of her prenatal records. So here in this area, all the doctor's office computers are not all, keyed into this hospital computer. So all the private doctors' prenatal records are on their own system. And what they have to do is about every month, they'll send all the prenatal records in for all their patients that are due the next month. So they'll send them to labor and delivery so that they're there. So if a patient comes in at 3 a.m., we can go and look at Dr. Hill's file and pull out a prenatal record on that patient and get some information on them. Otherwise, we wouldn't know anything about our history until the next morning. So they will send us, usually in advance, a copy of the prenatal record when the patient's about a month from her due date, so we've got information. That prenatal record tells us about our prenatal history, about our blood type, about our immunity to rubella, about our group B strep status, things like that. So I don't know if I've talked to all of you about group B strep, but just in case you don't know what that is, group B strep is a bacteria that is found. If we do a rectovaginal swab on pregnant women, 50% of the time they'll swab positive for it. It is not an infection if they're colonized with it. It is not infectious, an STI. Women in the healthcare field are almost always positive for some reason. Some exposure that we've had from, from work, I guess, but if you're positive for group B strep, it is not a problem for you at all. The concern is the baby. When the baby's born, babies, especially if they're premature or their immune system's somewhat they're a little bit immunocompromised at all, they can get a group B strep infection. And we have seen babies die of group B strep sepsis. So what we do is if mom's positive for group B strep, she screens, she's colonized, we give the mom antibiotics before the baby's born.
Mine was.
A lot of women, a lot of
She was the
women.
only one on the floor at the time that was.
Oh, your patient was?
Yeah.
So we screen them all, and we do it about 36 weeks. They do a rectovaginal swab, send it to micro, and see if they screen positive. If they do, they get antibiotics. If they don't, they don't. Now, what happens if the patient will come in and deliver too fast, or they don't get antibiotics? Then the pediatrician will assess the baby. The pediatrician may keep the baby in the hospital an extra day or two. The pediatrician may give the baby prophylactic antibiotics. It's up to the pediatrician. But if we can, we like to give mom antibiotics before the baby's born. That's ideal. So we're going to get access to prenatal records, get all that information, information on their pregnancy history, all those things that have been done throughout pregnancy, including group B strep status. We talked about rubella already, right? We want to know if they're immune to rubella, which is German measles.
I'm getting confused.
I heard. Good luck. We're just talking about having babies, so you're the right person. Right person to be here.
I'm the right person.
Well, and a matter of fact, are you going to see AMC? We'll be there tomorrow.
You will?
Yeah. We'll be there in the morning.
Hold
out.
Labor and delivery.
Yeah,
Combining.
we'll be there. We'll be looking for you.
There you go.
Good luck to you, Rachel. Did you have a baby tonight? Okay. So, we'll interview the patient, of course, do just like a database like we do on a med-surg patient. We're just looking for OB-specific information. Do they have any medical problems? Don't forget the domestic violence assessment that we talked about way back in the beginning when we talked about assessing your patient for intimate partner violence. Look for stressors. Does your patient have any stressors in labor? Do they not have a support person? Do they have financial stressors? And again, if I identify that there's a stressor, especially financial, I always come to see the other. Don't talk about that right now. Tell her everything's okay. Let her worry about the electric bill after the baby's born. She needs to be able to focus on what's going on. We want to eliminate and minimize stressors as best we can. If there are cultural factors that you need to know about, like your patient says, according to my cultural beliefs, I don't want a male examiner, I don't want any pork on my plate, or whatever it is. We need to be aware of that, and we need to respect that, in any way that we can. We do see patients from time to time, depending on their background, who do not want any male examiner. They have a female doctor, and they want only female examiners. That used to be hard to be able to provide, but now that we have as many female doctors as we do, it's much easier. It's not the nurse issue, it's the physician issue. Like, for example, if they have a private doctor, that's fine, but if there's an emergency, or something, a resident's around, we can usually more easily find females now than we used to be able to. But that's one of the common things that you'll see in OB. Then, of course, we're going to do just a physical exam like we do with any patient who's being admitted, system assessment, heart sounds, lung sounds, bowel sounds, pulses, all those things that you would do with any patient when they're admitted. Vital signs, baseline vital signs. Leopold maneuver. Anybody know what Leopold maneuver is? Leopold maneuver is when you try to assess the fetal position by using your hands. You touch the mom's abdomen, and you're not trying to turn the baby, but you're trying to feel. Is the head down? Is the head up? Where's the head? Where's the butt? You're trying to do that by feeling yourself. Usually, if you're very experienced, you can pretty much tell the butt from the head. And you can tell if the head's down or if the butt's up, if the baby's breech or if the baby's vertex based on feeling that. If there's a question and you're unsure, we can always do an ultrasound to confirm it. But Leopold's maneuver is an assessment that's done. Nurses can do it as well, but it's done by midwives, physicians, and nurses who are experienced to assess fetal position and life. It's not to move the baby, it's to assess how the baby's positioned. And then we're going to put the patient on the fetal monitor, we're going to assess the fetal heart rate, and we're going to assess the contraction pattern. So 2 things that fetal monitor tells us, baby's heartbeat and about the mom's contraction. And initially we're going to determine a reassuring pattern, which y'all don't know what that is yet, but you will soon. And for purposes of a baseline, and then if the baby looks good, then we can let the patient up to walk if she would like to walk. Once we've established a good baseline of fetal heart rate activity. So assessing of uterine contractions, remember that for those of you guys who've been in clinical with me, you know the external monitor that we put on the belly is called a TOCO, and that measures contractions externally. We can put an internal monitor in. You'll learn about that next week. That's called an IUPC or intrauterine pressure catheter. And that tells us about contractions. So when we're looking at contractions, we can look at this will be on your test. As far as terms, this will be on your test. I'm kind of talking about it, but everything about fetal monitoring contractions will be on your quiz, fetal monitoring quiz. So it won't be on this test next week. So we talk about frequency, intensity, duration of contractions, just kind of to throw it out there, but that's going to be on your quiz for fetal monitoring. Then we do a vaginal exam on every patient that comes in, or cervical exam, because we want to, if they're in labor, we need to know where we're starting from. Are they dilated? Are they effaced? What's the baby's station? RNs do that on a mission to all patients. Now, if I had a 3rd trimester patient that came in and said, I'm having contractions, but I'm bleeding, would I go in there and stick my hand inside that patient? Because what am I concerned about? What do I want to rule out? Placenta previa. Yes, because I'm worried about the placenta. She's having bleeding, and until I've proven that the placenta is not there, I don't go and check her. We do an ultrasound and make sure the placenta is out of the way. And if it is, then there's another cause of bleeding, and then we can then examine her and see what's going on. But any patient with bleeding, if you don't know for sure that she doesn't have a placenta previa, you never examine her until you are sure. But no, obviously, if a patient thinks they're in labor, without the presence of vaginal bleeding, we always assess their labor progress and then call the doc and report what their labor process is. What their cervical exam is. And then again, if they think they're in labor, we may say, okay, you're 1 centimeter, 50% effaced, and minus 1 station. Go walk. If the baby looks good, go walk for an hour and a half. We'll check you again. We'll see if you're in labor. Now, if they come in, we examine them. They're 4 centimeters dilated, 90% effaced, 0 station. They're getting admitted. So we see where we're starting from, and then make a determination of whether they're admit them or whether we'll let them walk and admit them later. I don't know why this slide is in this chapter, but we talked about it before. But this is just a reminder of what happens when you put a pregnant woman on her back. So look right here. This is the abdomen, the baby. So here's the spine. She's on her back. What happens to the vessels here? So you see how they're smashed? If you look over here, see where she's tilted? Now, she just got a little pillow tilt. It's not a big tilt. Just a little pillow here. Now they're nice and grounded, blood's moving through. So you want to make sure when your patient's admitted, we have a blanket on the side of the bed immediately. We always tilt them on their left when they're first admitted. That might be why that's in this chapter, admission of patients. Also, during a contraction, it also can affect blood flow. We talked about why contractions affect blood flow earlier today. But that just shows a picture of what happens to the vena cava when you put the patient flat on their back. Lab test. What lab test do we do? Well, at the minimum, we do a dipstick of the urine for protein, and if ordered, we'll send the urine for a UA. So what do we look? We're looking for protein for what reason? What are we looking for there? Preeclampsia. If it's 1 plus, that's equal to 30 milligrams in their dipstick, or if it's 24-hour urine, which is the only way we can diagnose preeclampsia with the 24-hour urine, then it's 300 milligrams or above is diagnostic for preeclampsia. So we're going to do a urine specimen at the minimum of a dipstick. We're going to do an H&H and a platelet count, and I just told you 2 minutes ago with H&H, we need to know where we're starting from because they're going to bleed during their birth, right? At birth is going to, equal blood loss. So if their hemoglobin's 8, we need to know that. And we do a platelet count, mostly for anesthesia. Now, if we suspected preeclampsia, we do more labs than that. This is for a normal patient, but if we think that they have preeclampsia, we would do other tests. We would do coagulation tests, liver function tests, and look at all those. A lot of times we'll get an extra clot of blood and just ask the lab to hold on to it, and that's in case we would need an emergency type of screen or type of cross for a C-section or something. So oftentimes we'll get an extra clot of blood just to hang on to it. And then group B stroke we talked about. Rubella, I think we talked about, but in case we didn't, just to remind you, rubella is German measles. We've all been vaccinated for rubella. Some of us, for whatever reason, have waning immunity. If you are no longer immune to rubella, and you get it during the first trimester of pregnancy, your baby can have all kinds of cardiac and limb anomalies. So we do not want pregnant women to be non-immune to rubella. So if you are not immune to rubella, it won't help you during this pregnancy because we can't vaccinate you during pregnancy because it's a live virus. But at the end of this pregnancy, we can vaccinate you in case you have another pregnancy. So if you're no longer immune to rubella, we can't help you during this pregnancy. We have to hope you'll get exposed to it. But we will vaccinate you at the end of the pregnancy, after, in case you get pregnant again or just for your own protection. But what we're concerned about is congenital anomalies due to exposure to rubella during the first trimester. And
Have you ever seen anything like, someone that,
several years ago I did. You don't see it much at all, but I did see a baby with limb anomalies from rubella exposure. I mean, it's probably been 15 years or more. But a baby had upper extremity anomalies. They had no limbs from here down. One time I seen that.
now was that a American patient or was it somebody that?
No, it was an American patient. She'd been exposed here somewhere. I mean, I don't think she knew where she'd been exposed, but yeah, she was not immune and doesn't know where she was exposed.
I was just curious.
Yeah. Just one time that I can remember seeing it. So this is going to be our last slide. We're going to stop right here, and I'll probably review this one again on Wednesday. Assessment of amniotic fluid. So what happens if your patient says, not that she comes in and she thinks she's in labor, but she says, I think my water broke. That's a different complaint. It may lead to the same thing, but if she thinks her water broke, then we have to determine did it. Because a lot of times it's not. That it's urine, it's discharge, it's something else besides amniotic fluid. Patients can get very confused about that. A lot of times the baby can kick and cause the patient to, express urine. So it may not be amniotic fluid. We have to make an assessment to determine it. Now, if somebody's walking, there's a puddle behind them. I mean, that's pretty safe. But, it's not always like that. Sometimes it's a little trickle, and we're unsure. So there are 2 tests that we can do to determine if it's amniotic fluid. One's called a nitrazine paper. Basically, it's a pH test. And if you touch the fluid to the nitrazine paper and it turns it blue, it's considered amniotic fluid. If it stays pink, then it's not amniotic fluid. There's a more specific test called a Ferning test, where you have to get a little bit of fluid on a slide, and the doctor has to look at the slide under the microscope. And if the cells will look like a Ferning pattern. And if it looks like a Ferning pattern on the slide, that's considered amniotic fluid. And that's definitive. So, and SROM means spontaneous rupture of membranes. Spontaneously, the patient's water broke. So if we're not sure, the nurse may touch the fluid with nitrazine paper, or the doctor may do a Ferning test when he may look at that fluid on a slide under a microscope. If it's documented that the patient's water's broken, they are admitted to the hospital. Once your water breaks, you are having a baby. With a very few exceptions, you're having a baby, no matter what. Spontaneous rupture of membrane. SROM. Spontaneous rupture of membrane. Now, that's SROM. AROM is artificial rupture of membrane. And in this case, if artificial rupture of membranes is done by the doctor, let's say the patient's already admitted and she's in labor and she's 5 centimeters, he says, let's drink your water to speed things up a little bit. That's AROM, artificial rupture of membrane. So either way, when your water is broken and you determine that that's what it is, we're going to assess for color, odor, document the time that it happened. If they say their water broke at home last night, what time? We need to know what time. It's very important because we want them to be delivered in 24 hours if possible. Your water broke at 11 o'clock last night? Okay, good. We're on the clock. 11 o'clock last night. So the fluid should be clear. It should not be foul-smelling. If it's green or brown, what does that mean? Meconium stained amniotic fluid. That means the baby's had a foul movement in the amniotic fluid. And in that case, we'll talk about that in the next chapter. That brings a whole other thing that we do to prevent the baby from aspirating that meconium. So actually, I need more time to talk about this. So we talked about diagnosing it. So we'll pick up here on Wednesday and we'll talk some more about that. But it's going to take me longer than take this class. So we're going to stop right there. We'll pick that up on Wednesday. So hopefully we'll finish 16 and maybe 17 is below.
Does anybody have anything for me to take to the meeting at all?
He's trying to,